Hi, I'm Rob Enns from Vancouver, and joining with me is Dr. Khashab, who joins us from as Assistant Professor, Director of Therapeutic Endoscopy at Johns Hopkins in Baltimore. I'd like to welcome him. Thank you for coming. And our topic today is a recent paper, International Multicenter Experience with Over-the-Scope Clipping Device for Management of GI Defects. This is a huge advance in GI care, and I think we're all excited about these instruments that have come out. And maybe what I'll do is ask you to kind of start with patient selection, because there's kind of a large group of different patients that are included in this study. How do you classify these defects, some of them perforations, fistulae? You want to discuss those a little bit first?
Sure. So we included consecutive patients with what we call gastrointestinal defects or GI defects. And with the GI defects, they included perforations, leaks, and fistulae. So a perforation is a full thickness iatrogenic defect, acute iatrogenic defect in the gastrointestinal wall, usually procedure related. So that's an acute and full thickness. A leak, usually it's an anastomotic leak, so that's at a surgical anastomosis. And leak, you can see it endoscopically or radiologically, and there's usually a collection. And then you have a fistula, which is a communication between two epithelialized surfaces. So these are the formal definitions that were based on in this paper.
Yeah, because I think it's important to get a little bit of a feeling for that, because then the next topic is what are some options available for us to close these, which are obviously, there's turning into a multitude of different options. So before we get to the paper and what was done, you want to talk about some of the options available and kind of how you think about them? Sure.
This is a very broad topic, of course. So just in a nutshell, there are multiple endoscopic options these days. The main thing, I think, is clips, the use of clips.
Right.
To close all of them with variable outcomes. You know, the current clips, the through the scope clips, the main limitation is the small size of the clip. Most of the clips, the jaw size, the opening jaw size is about 11 millimeter, and because of that, the ability to close larger defects is not optimal. The other thing also, the current clips, they provide mucosal closure and not full thickness closure, and thus really the outcomes are also suboptimal. The other options to treat these defects include stents by diversion. So this is diversion of fluid and gastrointestinal contents away from the defect. We have plugs, tissue adhesives, cyanoacrylate, so multiple options usually. And in many patients, especially with patients with fistulae, we end up doing multimodal therapy, combination therapy, just because of the difficulty in treating these patients.
And so this particular device, the over-the-scope clip, can you discuss a little bit about it and how it works before we get into the study?
Sure. So it's called over the scope as opposed to through the scope. So it's a clip within a cap, a hard cap, that you mount on the tip of the endoscope. Same as a banding device that you mount on the tip of the scope, but instead of the band, you have a clip. So you suction both opposite walls of the defect to within the clip, and then you deploy it. If the defect is too large, then you cannot suction both edges to within the clip. Then you have to use a device, an anchoring device, or a twin grasper that the same company manufactures, and you can help approximate both edges, pull inside the clip, and then close it.
I see. So the anchoring device you would use primarily for larger defects.
Larger defects. For small defects, you just have to suction both edges to within the clip.
Okay. And you want to describe the study that was done with this and some of the patients that were looked at and your outcomes of it?
Yes. So we decided to do a multi-center study because the current literature includes case reports and case series, and you cannot really judge outcomes and predictors of outcomes from small series. So this large multi-center study included 188 patients with 108 fistulae. We had about 48 perforations and 32 leaks. And we looked at outcomes, which is the long-term resolution of these defects. The overall resolution was 60%, but then if you break it per type of defect, perforations were pretty good in closing perforations. The rate of closure, successful closure, was 90%.
Oh, okay.
That for leaks was 73%. For fistula, as expected, it is 42%. But overall, it was 60%. And then if you want to break it in terms of, was it a primary therapy or was it the rescue therapy? Yes. So did these patients have prior failed attempts, and these patients constitute a more difficult to treat patients? So if it was primary therapy, the success was 69%. If it was rescue therapy, it was about 46%. So it goes down for rescue therapy.
And you would expect that.
Yes.
I assume that a lot of the fistula, particularly where the results weren't as good, some of them I'm sure had been tried on multiple therapies.
Yes. So if you look at it carefully, more than a third of patients have had prior therapy, but also I really think in our current practice now, the result of or successful closure of fistula is a little higher than 42%. Right. And the reason many of the endoscopists in this study were not aggressive in terms of applying APC to de-epithelialize the fistula, and only a third of patients had APC prior to fistula closure. I do think if we were aggressive in applying APC, this 42% probably will go up to about 60%. Still not that good, but better than we've had. We did like 3-4 years ago.
Exactly. So I mean, clearly it works, and this is a difficult group of patients. Now, what are some of the complications, or perhaps also some of the patients where you might not use it at all? Are there some times when it just doesn't work, or you wouldn't even try it?
There isn't anything like it's a complete contraindication, but you have to be careful when there is a stricture, because this is a hard cap. A stricture and narrowing, so you have to know which cap you're using, what's the diameter of the cap, and sometimes you have to dilate a stricture before you go through. Also, deep small bowel defect, they are hard to get to, just because of the hardness of the cap. Similarly, proximal colonic defects, it's hard. So it works really well for left colon, proximal small bowel. Deeper than that, some of the patients actually in these difficult locations were reported in this study, but in my experience, it's hard to get to.
And what about certain angulations, particularly the post-gastric surgery patients where you kind of have to go around a little corner to get to the defect? Does that ever create an issue?
It does. So two things is the difficult location and then the fibrotic edges. So difficult location can be a big problem, and you just have to use your endoscopic skills, and sometimes it's going to fail because of that. We did not have failures due to a problem getting to or getting good angle. All the failures were due to fibrotic edges, mostly in fistulae, which means it's hard to grasp edges or grasp them with a clip because they're fibrotic.
So this is a somewhat heterogeneous group, and there's going to be different physicians at different times. Some of them will be acute perforations, some of them will be seeing, fistula. Do you suggest, well, two questions. One is about training, because it's not used that often. You had to do a multi-center trial to find all the experience. What's the training with it, and do you try to have 1 or 2 people in your site use them primarily?
Experience matters, of course, and the way you operate the clip is really not difficult because it is similar to a banding device. So I think all gastroenterologists have the ability to use this clip. I don't think it's an advanced device where only a select group of people will use it. I really think knowing about the approach to gastrointestinal defects, the multimodal therapy, the different things that you need. You can't be able, you don't treat fistula if you only know how to use an over-the-scope clip. You need to be able to know about tissue adhesives, plugs, stents, etc. And so you have to have complete knowledge of all of the above. But in terms of the over-the-scope clip itself, I really think it's simple to use.
Okay. Well, I'd like to thank Dr. Khashab for joining us today from Johns Hopkins. I appreciate the whole input that the group has actually had in this, and also everybody that was in the multi-center study for this contribution, because I think it does make a huge impact in patient care and is one of the huge advances that's occurred lately. Thank you very much.
Thank you.